Welcome to Skin of Color Savvy, the art and science of treating patients of color, the official podcast of the Skin of Color Society. Produced by HCP Live and hosted by SOCS leaders, Skin of Color Savvy delves into the latest research, clinical insights, and culturally intelligent and responsive care practices in dermatology with leading experts. Whether it's groundbreaking research, practice-changing insights, or highlights from our vibrant community, we're here to provide dermatologists and other healthcare providers with expert perspectives on treating patients with skin of color. Let's dive in and explore how we can continue to advance care and make meaningful impact for all patients together. I'm Dr. Victoria Barbosa. I'm an associate professor of dermatology at the University of Chicago and director of the hair loss program here. I'm also the current president of the Skin of Color Society. And it's my pleasure today to be joined by my good friend and colleague, Dr. Janiene Luke. I'll give her a chance to introduce herself in a moment, but before that, we are thrilled to bring you this episode on myth-busting and truth-telling on hair care, patient habits, and managing hair loss in skin of color. Dr. Luke, please introduce yourself to our audience.
Thank you so much. I'm so excited to talk to you about this topic. I'm Dr. Janiene Luke. I'm a clinical professor at the Loma Linda University, Department of Dermatology. I'm also the residency program director there, and I serve as a SOCS board member as well as the media relations co-chair.
So, Dr. Luke, I've been looking forward to this conversation with you. Let's jump right in. First, I want to know, what are some of the common misperceptions about hair care and hair loss that you see in your patients with skin of color?
Yeah, this is such a great question. And I commonly encounter the name alopecia itself. Just the term alone, I think people are kind of self-diagnosing and they don't really understand that this term encompasses so many different types of hair loss with so many different varying causes. So I find that, patients will come to me and they'll say, Dr. Luke, do I have alopecia? And I'm like, yes, but that just means hair loss. And so while they're thinking, I just have alopecia, they're not really understanding that we really need to get to the proper diagnosis so that way we can really get to the best treatment option for them.
I see that all the time also. I'm so glad you brought that up because I will go through a whole visit, right? Explaining what I see, explaining in layman's terms the differential, what we need to sort out. And at the end of the visit, and I often say hair loss instead of alopecia to make the conversation accessible. And they'll say, so I don't have alopecia, do I? And I always say, dear heart, if you called me, you have alopecia. That's not the question, right? That just means hair loss. The question isn't if, the question is why and what we can do about it.
Absolutely. And then another thing that I always encounter is around the idea of protective styling. And I'm sure that this comes up for you a lot as well, too, where patients will come in and they're saying that they're doing protective styling, but they're really engaging in some traumatic hair care practices because some of the styles are too tight or they're left in too long or they're having a lot of symptoms from the styles. And so really, when we think about protective styling, ideally, we'd like something that just kind of gives the hair a break, where the hair can kind of sit and, really get still get the nutrients that it needs, still get moisture and water, but also, not really be having the daily manipulation and some of the other things that can cause breakage and other issues. And so I think, a lot of times people are really caught up on, I'm doing a protective style when indeed they may be inducing a little bit of harm.
Right. I feel like that terminology is just so misleading for people, right? Because they're well intended and they need to be educated that you might be protecting your ends from styling for a few weeks or months, but you're damaging your follicles, right? And so there's a lot of education. And that actually leads me to another question, because many of us are under time constraints in clinic, right? So, having a conversation about styling and also, doing, getting a good history and doing a good exam and deciding next steps is very time consuming. When some of these patients are have very strong feelings, are often very emotional. So that leads me to two questions. One is how how much detail do you go into with these patients about hairstyling? How do you manage that with the time constraints?
Yeah, I remind patients that we have a long-term relationship. We're not going to answer all their questions. We're not even going to get to all of their concerns maybe in the first visit or even, the next visit, depending on how many concerns they have. A lot of patients will just, oh, by the way, my hair is falling out after we've already done the full visit and we've spent a lot of time. So I just remind patients, one, this may take multiple visits. And we really do. It's very time consuming for me. I'm training residents. And so we really get in there. We ask a very thorough history. We're asking everything. And when the residents come out, then I'm asking even more questions, even things that they may have left out. We ask about, their medical history. We ask about whether or not they've been under any stress. We ask about their hair care practices in particular. I want to know, what type of styling are you doing? And so we really do get into the nitty gritty, and it's definitely not just like a quick visit. We may need to schedule a few visits to make sure that we get through everything. I do try to talk to patients as much as possible, especially if I feel like we're going to need to do a biopsy. So that way we can at least get that done and have a really, thorough history and really try to get to what exactly is going on.
So I absolutely love what you're saying. I have learned the same. A few things. One is I will only do hair loss. So at this point, about 90% of my patient care is hair loss. I'll see 30 hair loss patients in a day, which is not a small feat, right?
Right.
Um, and and you cannot, oh, by the way, me, right, with toenail fungus or
No.
marks on your pinky toe, right? The hair loss takes more than a full visit, right? We schedule it 15-minute increments.
Yes.
Um, so I don't even do a biopsy the same day as the initial visit. I find that getting a really good history and having a conversation about what I'm seeing and what I'm thinking takes a visit. I also find that most patients don't come in thinking a biopsy is even in the realm of possibility, and they've got to get their mind together for that. So I spend a lot of time prepping them for it and telling them, listen, when you wake up on biopsy morning, you're not going to want to come, but you bring yourself in here anyway, because we are going to do what we need to help you. And then we have a follow-up conversation now based on time constraints, usually by phone, to then I prep them for the treatment plan. But if, there's a biopsy, we're going to talk about the treatment after I get the results. So we spread it out. These are long-term relationships, right?
Absolutely. I have a similar approach in that, sometimes, as you know, and you probably have the same thing, people have waited a really long time to come in to see me. Anybody who sees hair loss, they have a long wait. So I discuss that. And if people are prepared and we can do the biopsy on the same day, then we'll do it on the same day. But like you mentioned, some people are not in the mindset to have a biopsy done on the same day. But I just let them know, we'll work you back in. We'll be able to do it on a different day when you're prepared. And so that, again, like you mentioned, we're putting the plan in place. A lot of times when we do a follow-up visit, I'll say, okay, we're going to follow up in 3 to 6 months from now. And they're like, what? And I'm like, no, no, no. We're going to have already discussed the results. We're going to have put the treatment plan in place, and it'll be a follow-up of that. So I find that really laying things out for patients and letting them know what to expect tends to work pretty well for me. And it really does allow patients to have their concerns addressed over multiple visits.
Thank you so much for these tips. Let's dig in a little deeper on some specific forms of alopecia. What types of hair loss are you seeing most commonly in your patients with skin of color?
Yeah, thankfully, like I mentioned, I'm in Southern California, so I do see a wide variety of patients. I also see children and adults. So I see pretty much everything, lots of non-scarring, but also a lot of scarring alopecias. So I see alopecia areata, I see a lot of AGA, androgenetic alopecia in people as they're getting older. And then I tend to see, especially my patients of color, a lot of CCCA, central centrifugal cicatricial alopecia. I see a lot of, LPP. I see a lot of frontal fibrosing alopecia. And I will get on my soapbox for just 1 minute
Please
because a
do.
lot of these patients are misdiagnosed as traction alopecia. And not all, hair loss is traction. And then you really have to look at those eyebrows because people will tell me, oh, I have traction alopecia. And then I look at their eyebrows, they have no eyebrows. And it's like, no, 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 no. We have something else. We're dealing with something else. So I see a lot of subtle diagnoses as well, fibrosing alopecia in a pattern distribution, and people who were told that they had androgenetic alopecia, and they thought that that was the case for many years. And so there are a lot of mimickers, and I feel like it's really important to, again, look very closely, be nosy, ask a lot of questions, and then if you need to, biopsy.
I think you have hit on such an important point. I think sometimes physicians make assumptions about diagnoses because the patient, particularly is a Black woman, right? So
Absolutely.
I would like to point out that sometimes people shortchange the evaluation of scarring alopecia at the frontal scalp or crown, assuming it's CCCA. I've got a ton of Black women, because most of my patients, not all, but most are Black women, ton of Black women with LPP, right?
Absolutely.
And so I think that gets missed a lot. And the number of times that women are assumed to have traction when there are plenty of clues like the eyebrow loss, also like facial pigmentation, right? Which is lichen
Absolutely.
planus pigmentosus. And they're just, it's your traction. You did it to yourself, too bad, so sad. So people have to be observant. The other thing that has happened to me several times is that people have come in for eyebrow hair loss or for evaluation of facial pigmentation, and they're wearing a wig. And
Yes.
you have to be perceptive enough to say, I know you're here to talk about your eyebrows, but I need
Right.
your hairline. And
Yep.
boom, it's
Okay.
FFA.
Absolutely. And then to your point too, people often have more than one type of hair loss. And when you've been doing this for, long enough, you'll notice like, yes, they have a little bit of traction, but they also have CCCA. They also have an androgenetic component. And so I find that there can be concomitant hair loss of multiple types going on in the same patient.
Absolutely. I see the same as often as not, right?
Mhm.
Sometimes it's AGA plus,
Mhm.
sometimes it's CCCA plus. And
Sure.
so I really try to teach the residents that you have to examine the whole scalp. Sometimes there's, some occipital hair loss that can also be traction or
Sure.
occipital fibrosing alopecia or whatever. I've had patients who have CCCA and alopecia areata. I've had that a few times. So again, it's important to keep a open mind, a broad differential, and to do a thorough exam and ask about body hair as well. So you mentioned biopsy. Let's talk about some of the tools that we sometimes use in evaluating our hair loss patients. Tell me, how often are you using dermoscopy? Let's start with that.
Well, I actually use dermoscopy daily. I love using my dermatoscope to really look at the follicles. It gives us so much information. And for me, when I'm thinking inflammatory scarring alopecias, I'm definitely looking for lots of clinical clues. I'm looking for those gray halos if I'm thinking it's CCCA. And I often do dermoscopy guided biopsy. And that's really helped my diagnostic yield, where I've been working with my dermatopathologist for almost 15 years. If he's like, oh, she put on there CCCA, it's probably CCCA. And sometimes the clinical entities or the histopathologic findings can be a little difficult. But I think having that relationship and really having them, take a look, they'll give me the read. But if I'm like, no, this looks like CCCA, but like you mentioned, sometimes it's LPP, and I've seen like perifollicular activity and on or dermoscopy, and that's given me more of an inclination that we're dealing with something else.
So I too am using dermoscopy, trichoscopy all the time now. Now, I'm no young spring chicken. So I trained before trichoscopy was in widespread use. And so this is one of the many areas of dermatology where I've had to really learn as I go. And fortunately, there are so many great tools. There are trichoscopy courses, there are courses at the AAD and other meetings. So this has been one of many areas where things have really changed, and it's been kind of really fun and exciting to keep up. So now here's a question, and there's no right answer, even among those of us who see a ton of hair loss patients. Some people will use their trichoscopy findings in lieu of a biopsy. Some use it in addition to a biopsy. Do you find that you're biopsying less because you're using trichoscopy, or are you just using them as different data points?
I use them as different data points, but I also remember who's in front of me too. Some people are so nervous about the biopsy, even though I can. And for us, I have to also remember for us, it's routine, right? It takes us 5 minutes. We do it all the time. But for patients, it sounds like a really big deal. And so I also have to be mindful of who's sitting in front of me. So if someone is terrified and they can't even fathom the thought of a biopsy, I let them know. It helps me confirm what I already think is going on. And if they're, and most people do really want that confirmation. And so a lot of times, again, it's just patient centered and patient directed management where we're kind of having these conversations. And I kind of go with what, they think. If I think they absolutely need a biopsy, like I'm between clinical entities or, the picture's not as clear, then I will kind of voice that to them. But I still go with, what they're most comfortable with, knowing that even though it's routine for us, it does sound very scary for patients.
I really love what you're saying, which is partnering with the patient to make a choice that they're comfortable with, right? I'm sure the same is true for you that it is for me. Sometimes I'm people's second or third or even fourth or fifth opinion.
Mhm.
And I always start those visits by asking you, I say, listen, you've seen 3 or 4 or 5 other brilliant dermatologists. What are you not getting?
Yeah.
Right. And sometimes it's that people have been too authoritarian, too, busy directing something that they just haven't worked up comfort, to
Yeah.
address. And I joke with my patients. I say, I'm going to see 30 some odd hair loss patients today, and I'm not going to save one life. Right. So everything I do is a suggestion. You've
Mhm.
come to me because I've been doing this for a long time. I know what I'm talking about. Right. But at the end of the day, it's important to me that you are comfortable with what I'm suggesting, because you know what? Otherwise, they just don't come back. Right. And then you can't take care of them. So I think you are spot on there.
And to piggyback on what you just mentioned, not only with the biopsy and being suggestive, a lot of times people have come to me after seeing other dermatologists who didn't examine them, didn't touch their scalp, and kind of looked at them from across the room. So it's really important to incorporate cultural humility and really understand the person that's sitting across from you. How can you look or diagnose anything if you haven't looked or you haven't touched their hair? And you can decide to wear gloves or not, or whatever your preference is, but I do think you have to get in there and take a look at their follicles in order to see what's going on.
Absolutely. Absolutely. And you know what? Sometimes you have a pretty good idea from the door,
Mhm.
right? But people feel shortchanged, right? If you
Absolutely.
haven't done that. I will also highlight, in the spirit of cultural humility and cultural intelligence, that I do let people know it is time for me to examine your scalp. May I
Mhm.
touch your scalp? As
Yes.
many of our listeners, but maybe not all, know, especially for Black women and Black people in general, touching our hair and our scalp without permission can be very triggering. So, and I'll sometimes even touch a shoulder before I'll touch the scalp
Mhm.
to get them comfortable with my touch.
Absolutely. I do
So
the
yes,
same.
thank you for bringing that up. I do want to dig deeper on traction and on CCCA. I want to hear a little bit about your management strategy for traction alopecia.
Yeah. So again, it's one of those things where I remind patients that, yes, some of the practices are, exacerbating or making their condition worse. I try to do everything without any blame or stigma for the patients, because again, it's one of those things where, they're seeking our help. The last thing we want to do is make them feel bad about, what it is that they have or anything like that. And then I also remember that people have to live, they live their lives. And so I talk about, and like you mentioned, I love the fact that you mentioned that you're constantly making suggestions. I'm constantly making suggestions as well. And I love Crystal Agu wrote an article about not all hairstyles are created equally. And so I love that, not just telling people you can't do these styles, but offering recommendations, but then offering guidance based on the types of hairstyles that are more high risk as opposed to those that are low risk. And really, again, it depends on who's in front of me and really just determining, what styles are going to work for them. Sometimes, you can tell your patient, don't do anything traumatic. And then they're like, well, what am I going to do?
Mm-hmm.
So you have to have
You have to
those
have an answer to that.
conversations.
Right?
Yeah, you have to be able to offer suggestions and recommendations.
Now, are you using topical steroids? Are you using intralesional Kenalog? What else are you using in
Yeah.
addition to counseling them to better hair styling choices?
I am doing intralesionals. I will do topicals if people are needle phobic, but I do kind of remind them that we want to get the medicine exactly where we need it to go, which is deeper down. And so I remind them that, ideally the injections would be the first way that we would like to try to treat this. I also offer, topical Rogaine or minoxidil. I often work with compounding pharmacies. So, like I mentioned, if there are other components to the hair loss, I may mix in other ingredients. I do discuss platelet rich plasma in some patients. And then, if it seems really severe or we've tried things, they can also consider hair transplant. And there are several of my colleagues across the country who specialize in doing hair transplant in textured or curly hair. And so that sometimes is an option for them as well.
I love that. So I'm using a lot of the same treatment modalities. Once again, I feel like a lot of our hair loss patients already have a sense of loss of control. So I try to put some control back in their hands. And what I tell my traction patients is that you have homework and then there's an optional in-class assignment. Okay, this is how I phrase it.
That's great. I
Multiple
love
times a day.
this. I'm
And
learning
so
something today too.
and so the homework is a topical steroid and minoxidil. And I give them a choice of topical or oral because a lot of them also have
Yeah.
some female pattern hair loss. And so
Yeah.
I say I prefer the oral. It's a little I think it works better because it's easier to be consistent.
Correct. I agree.
But I give that's their choice also. And then the optional in-class assignment is the ILK.
Mm-hmm.
And I would say 50-50, maybe
Mm-hmm.
60-40. Most people have a little trouble wrapping their heads around multiple injections at one time, even though we know it's going to be quick.
Mm-hmm.
So I will do a higher potency topical plus the minoxidil if they opt to only do homework first.
Sure.
If I'm also going to do ILK, then I'll give them something a little lower potency in between. And I'll tell you, sometimes just the homework is enough for them to see results. And if not, I'll see them back in several months.
Mm-hmm.
And then they're like, this isn't enough. Bring on the syringe.
Agree.
I also love your bringing up the issue of hair transplant because these are really the patients who are the best transplant candidates. They don't
Mm-hmm.
have an inherent disease.
Mm-hmm.
So if they stop the traumatic practices, the procedure really usually takes very well.
Yes.
But I too find that they need to find a transplant surgeon who is experienced
Mm-hmm.
in transplanting curved follicles.
Absolutely.
Do you have someone local that you refer to, or do you send people to travel for their transplants?
We do have someone in California, Dr. Umar. So I refer a lot of my patients to him. He's out in Redondo Beach. And so he's very well versed in curly hair, does transplant. He even created a device that helps extract the curly follicles. So it's been great. I've been able to send a few patients over to him.
Mhm. Wonderful. I too have a local person, Dr. Yates, who's amazing, but I have
Oh,
also
yeah.
sent people to Mina Singh, to
Yes.
people in DC, to New York. Um, fortunately, this is a procedure that people can travel for. So if someone finds themselves in a community without an experienced transplant surgeon, it's not unreasonable to take a short trip to find one.
Definitely.
I want to pivot a little bit and talk about CCCA. And this, again, is an area where there's not one right answer. So I'm curious to hear how you approach managing patients with CCCA.
My approach is kind of two-pronged. So, first and foremost, we want to stop the inflammation and halt the disease progression. So, we talk about one side of the treatment arm will be dedicated to that. And that'll be, we can do topical steroids, ILK, we could do oral doxycycline, just really depending again on their level of comfort and really what they're interested in. I tell them combination therapy tends to be key. If they're having symptoms, then we talk about rescue therapy with topical steroids if they need it. And then we talk about the, growing or regrowing component. I remind patients that, when we have scarring and damage to our follicles, the likelihood of them regrowing is sometimes a little bit lower. But I also remind them that if there are viable follicles, we do want to try to stimulate them so that way we can get better camouflage and their spot maybe may not look as large. Or in some instances, we can get a little bit of better regrowth if the follicles aren't completely damaged. So here's where, again, we'll do, minoxidil. I typically do like oral minoxidil at low dose because these patients can tolerate this and it does do very well at stimulating those other follicles that may be kind of in the vicinity. I do like PRP. I've been very excited with the results of Dr. Agu's study with metformin.
Yeah.
And I have had quite a few patients that have tried that and have been, very happy with their results. So I do topical metformin, but then have been recently doing some oral metformin as well. And then, of course, if people want to do everything, we talk about PRP and other things like that.
So you have opened so many additional questions. So first, let me say that my treatment approach is very similar. I tell people goal number one is to keep things from getting worse. Goal number two is to try to bring some back. And sometimes we get a little regrowth. Sometimes we get something near a miracle, and sometimes we get nothing, and we won't know till we try. And people can understand that. And honestly, I find that in the end, most people can come to some sense of inner peace with their condition if they know that you have and they have tried everything. I too will start with doxy and topical steroids. I tell them we're going to treat you from the outside and from the inside. And also I throw on a little keto shampoo for funsies. And then at some point we'll select from minoxidil usually, or finasteride or spironolactone or dutasteride. So I'm curious to know what dose of minoxidil you start with for these patients.
So I used to be like, cut it in fours and do like itty bitty, but now I just start with half a pill. And then if they're tolerating that and they're not too mad at me for any excess facial hair, then we'll go up to 2.5. So usually around there is where people can be okay. And most people, like I said, unless they're mad at me about facial hair, we're usually okay.
And I do exactly the same. Plus, they're teeny tiny pills and they crush easily. So I tell people to get a pill cutter, but cutting in quarters, unless someone has real concerns about their blood pressure running on the low side, I just didn't find that to be feasible. I will say I do spend a fair bit of time counseling them also on fluid retention.
Yes.
I've had not an insignificant number of patients have some ankle swelling or even hand swelling, but I've also had a few patients end up with shortness of breath, which resolved for the two of the three patients who remembered to stop the meds right away.
Exactly.
The other one is fine now, but she kept taking it for 2 months. So that, After a brief
Yes.
hospitalization, she was fine.
Oh my goodness. I know. If they do have any cardiac history, we're very collaborative here, and I'm sure it's the same at your institution. We just touch base with the cardiologist. If they have any, cardiac history, we'll kind of really talk about that and get their blessing before we start it. I do remind patients that it is low dose, to your point.
Mm.
Most of the time they tolerate it very well.
Same. And fortunately, we've got, wonderful communication with the cardiology team. I'm also, if there's any concern, I just pivot to finasteride or dutasteride, which I think also works quite well. And a
Hmm.
lot of these patients end up on both,
Yeah.
right? Um, okay. So then I wanted to come back and talk about your experience with PRP. One of the big barriers, I think, to trying PRP is just the cost. So, we might have different patient populations. I'm not sure. Is PRP within reach for most of your patients?
It is. And I think this is also too, we do a special cosmetic clinic. A lot of our medical services are things that, are still considered cosmetic, but we're doing for medical reasons. We try not to charge a whole lot for patients. We really just want to provide the service. I'm not over here trying to get rich, seeing all these patients, but I have the luxury of being in academic practice. So we just basically, charge enough so that way it covers our staff, it covers the cost of the kit, and all of the things that are kind of entailed with it. We do offer a slight discount if patients are okay with our residents doing the procedure because it's part of their training. And so we do find that quite a few patients opt to have the procedure done because it's still pricey. So it's not like it's, anything. And then I think also similarly because of our institution and our demographic, we kind of do it a little bit differently where for my scarring patients, I don't do back to back to back because, there's no standard protocol, but I do space out the treatments. And so they do their treatments every 2 to 3 months instead. And I think that's a little bit easier on their pocketbook. And then they're able to do the series of treatments.
So back to poor management of CCCA, one of the things I find is that for some people, we're able to get it under control pretty quickly. For others, they have a more significant kind of remitting and relapsing course. So just tell me a little bit about step 2 for you if step 1 isn't cutting it.
I've been offering a lot of those patients the metformin. I've found that, if we haven't been able, and we've kind of been doing several things or a lot of combination therapy, that's been very successful, either topical, but now, like I mentioned, I've been doing oral minoxidil. I am excited about, all of the studies and research that's been going on with JAK inhibitors. And so I'm looking to see how that's going to do, especially because there's really no FDA approved treatments for any of these scarring alopecia. And
Correct, which
so
is so frustrating.
it's so frustrating, especially with coverage and things of that nature. I find that it's really hard for me to get the JAK inhibitors covered, but I'm excited to see what the research shows. And I know that there have been some promising studies, especially in scarring alopecia.
Yeah. I will say that I will give people a couple of rounds of Doxy, right?
For sure.
People are
For
needing,
sure.
my initial course is usually about 4 months.
Hmm.
Okay. And then beyond that, usually it only takes 2 to 4 weeks to get a flare under control.
Hmm.
But if someone is needing doxycycline more than 2 or 3 times per year, then it's time for me to pivot. And
Yep.
my pivot is still fairly often hydroxychloroquine,
Hmm.
which I find, is usually enough to do the trick.
Yes.
I too am so excited by so much of Crystal Agu's research, both in helping us understand, etiology as well as, identifying potential treatments. Now, I have not had great success with topical metformin, but I am excited to see more data with oral metformin. For me, that is still, I've tried everything else, And then we have this also, which is,
Yes.
kind of low risk and potentially high reward. So I look forward to more data there.
Same. Yeah.
Like you, I am also incredibly excited about the JAK inhibitors. Obviously, those are only approved for alopecia areata. Some people have had better success than others in terms of getting it approved for scarring alopecia. I do have a few lichen planopilaris patients
Mhm.
for whom it's been approved. I have not had it approved for CCCA. But there are some small studies, some letters to editors, etc. And so that has to be the next frontier.
Yes, I will see. And thankfully, there are enough studies to your point where we can include those studies and sometimes get it approved. It may take several rounds of back and forth with insurance companies, but I find, especially for my LPP patients, they just keep getting worse. Some of them, if we don't do some of these other things. So I try to offer, and like you mentioned before, just kind of exhaust all of our options. And so patients really feel like, okay, even if what we've got is this, we tried everything.
Mhm. I want to circle back on big picture advice that you give to patients. So we talked about hair care practices. I just want to circle back to find out if there are products that you favor or products or ingredients that you caution patients about.
So the most important thing that I remind patients, especially for my like afro textured curly hair people, is moisture to the hair.
Mhm.
And so I always recommend water-based products. And sometimes it's really a trial and error. And a lot of times, people will be like, well, I went on YouTube and I did this. And it's like, even if someone has a similar texture to yours, the products may not work for you. And so I just remind them that, they can look for water-based products. They should be conditioning their hair. I do ask about wash frequency. And if it's like once a week or once every 2 weeks, I'm usually okay with that. If it gets beyond that, then I am actually suggesting and strongly recommending that they do either once a week or every 2 weeks. So I do like those things of getting on a good hair care routine. Sometimes we'd be just surprised with a little TLC how the hair can recover and what, we may think is like bald spots or, patches or breakage, really it's just the hair kind of needing a little extra care. And so I do talk a lot about sulfate free shampoos. So that way the hair doesn't get stripped from its, moisture. I talk about, deep conditioning as well as conditioning. And then I talk about in their stylers that they be water based. And then I kind of caution some people who like to grease their scalp or, use certain oils and things of that nature, especially if they have seborrheic dermatitis that can sometimes worsen that. And so I just kind of remind them that oils are going to sit on the surface of the hair and not really, impart moisture for the most part, depending on the oil, and that they really want to moisturize with water. So that was kind of long-winded, but
Oh, that was perfect. And I think you've also uh, touched on some really important points, circling back on cultural humility and cultural intelligence. And I see this mistake happen all the time. It's really important for people to understand that, especially for Black women, shampooing every 2 weeks is normal. And it really, although it might not be our preference, it's also not surprising for us to hear that women are only shampooing every 3 weeks or once a month, or if they have
right,
braids or crochet, and it might be every
right,
6 or 8 weeks.
right,
It is really disheartening for patients when someone who is not familiar with these practices expresses surprise or disdain. And unfortunately, that happens sometimes. So I think that part of cultural intelligence is recognizing that you might think that there's a better approach for a patient, but expressing surprise or over concern about
right.
pretty common cultural practices is not a way to have that patient come back and see you again for follow-up.
Right. And then understanding that, there are tools and like I mentioned, things that you can recommend. I love the newer shampoos that have like the nozzles where you can get in between your braids, you can get underneath your tracks. And so, really reminding patients that I'd love for you to wash more frequently, but if this is where we're at, this is what you can also do.
Hmm. Absolutely. And I think if I will leave people with a final thought, we've talked a lot about specifics because we see these patients and we've been living with these products our whole lives. I think it's important for people to know that you can learn about hairstyles, right? So that you can have an intelligent conversation with your patient. You can learn about products if this isn't your culture, um, at baseline. And if this feels overwhelming, it's also okay to find a few stylists in the area to partner with,
Mm.
right? And then send your patients to a knowledgeable stylist to have a conversation about safe styling practices or what products are appropriate for their hair. So you can build a network of support to help you help your patients.
Absolutely. I literally just did this yesterday where one of my patients was transitioning. And so she was concerned about her natural hair and her hair that had been relaxed kind of breaking. And I did just that. I was like, have you ever thought, because she was the one who was relaxing her hair, she was the one who was doing everything. Have you ever thought about going to a natural stylist? And she was like, hmm, we haven't. And so I think, again, just having those connections, having those partnerships, and being able to put your patients on the right path, they're going to love you even more for that. And it's very easy, like you mentioned, to learn about some of these things. We teach the residents about these things so that when they go out into the community after they're finished, they do have this awareness. And then the learning never stops. You can always look and see what's new. I mean, even for us, we're always looking to see what's new and what else we can learn and add to our armamentarium.
Absolutely. And I think that is a perfect place to end today's podcast. Dr. Luke, thank you so much for joining me. This has been such a fun and informative discussion.
It's been my absolute pleasure. Thanks so much for the invitation.
That wraps up this episode of the Skin of Color Savvy. Dr. Luke, thank you so much for your time and for your insights. We hope that you found today's discussion informative and inspiring. If you're interested in learning more about the Skin of Color Society and its impactful work, I encourage you to visit skinofcolorsociety.org. Please don't forget to subscribe to HCP Live's newsletters and follow us on social media to stay up to date on the latest in dermatology and more. We'll be back soon with another episode, so be sure to subscribe to Skin of Color Savvy on your favorite podcast platform. Until next time, take care and thank you for listening.